final one. We have only 35 minutes for a 36-minute session. So over to the debate, and we are going to have on the poem we saw this morning, whether the poem is the best or the lap heller. You wait to see with the judge, John Tanakumar, is taking the chair. Over to the debate. Dear delegates, we are now moving to an important final session today before our plenary session, that is the debate. This debate is going to be for the next 30 minutes, and this is on a very important chapter wherein we are going to discuss which is the standard of care and ideal when it comes to the treatment of achalasia cardia. Is it poem or lap Eller's myotomy? To do that, we have three personalities here with you. We have Dr. John Tanakumar, who is our chief advisor, past president of IAGES. As all of you know, he is the trainer of the trainer, and he is the go-to person whenever it comes to the teaching and training as far as the various fellowship programs of IAGES concerned for the last 3 decades. And he is going to be the jury, chosen rightly so, for this topic. And to do this discussion, we have 2 academicians. To defend the case of lap Eller's myotomy is the best, we have Dr. Kanakavel, who is actually EC member, working as a consultant surgeon in Isabel Hospital, Chennai. He is incidentally also our IAGES newsletter editor and also the upper GI, the subspecialty editor in our JMAS. So with this academic credentials, he is going to put forth his views in defense of the surgeons. While we have the heavyweight champion from Pune, Dr. Amul Papai, he is going to defend the importance of this poem. That is what he's going to talk, because all of you know Amul has been in this field of interventional endoscopic therapy, endotherapy, for several decades, and he is the first one to do ESD and third space endoscopy as far as India is concerned. And I'm sure on his experience shoulder, he has done hundreds of poem, and he is chosen rightly to give all the facts and figures in front of us to say that poem is the future. So with that, I invite all of them. I request John to take over the proceeding.
Good evening, ladies and gentlemen. It's my pleasure to invite you to today's interesting debate on the treatment of achalasia cardia. It's between the present poem and the Eller's cardiomyotomy. Eller's cardiomyotomy was initially started in 1913, and the poem was as recent as 1990. So about 8 decades have gone past, and it's not long ago that we used to have debates about whether we should do open Eller's or laparoscopic Eller's. Now the time has come for us to wonder whether we should continue with lap Eller's or whether we should go on to poem, which is basically a new technique, at least for most of us. I first invite Dr. Kanakavel.
With the blessings of my guru, Professor Chandramohan, I start the day. The parameters which I'm going to touch upon are the availability of the services, learning curves, procedural challenges, what are the outcome differences between the 2 procedures, and long-term outcome. The availability depends on 2 dimensionally different things. The expertise of endoscopy and surgery are not comparable. They are 2 dimensional different specialists doing same procedure, but of course during a different axis. And the infrastructure, what is needed for a regular surgery and endoscopy, are hugely different. The learning curve at this point of the various guidelines says poem needs 100+ procedure and not less than 70 procedures. Whereas laparoscopic Eller's myotomy says a minimum of 30, ideally 50. So the feasibility of someone to get this number of cases is going to be a challenge. And of course, people, unless they are with a specific center, myotomies are better done or done with some supervision. So the treatment goal, as Dr. Tanakumar sir was telling about the various aspects of myotomy, let me jump into the bandwagon up front. The dissection or splitting of the LAS muscular fibers, however longer towards the esophageal side or the gastric side, remains the principal step. Now let us see what are the conditions LHM scores over the point. At this point of time, very recent publication, couple of months before published, you can see the network geometry of trials. This obviously scores. LHM and the pneumatic dilatation are still a large amount of work which is happening, and poem is just catching up. That obviously means still a laparoscopic Eller's myotomy has a very good say. And the number of studies and the trials being published also speaks about it. That obviously means it is still there, existent, it's not going to go off that easily. So this is yet another very well done meta-analysis of POEM versus Heller's myotomy. Efficacy is comparable in one single go. So efficacy parameter is out. Then comes the ECAT score of laparoscopic Heller's and POEM. They are comparable. So this goes out of the debate. Then comes the problem of reflex. Reflex is not what is the only thing which is perceived as a reflex by the patient or by the subject who has undergone the procedure. Reflex is much beyond. Apart from your clinically significant reflex, there are many parameters which have to be taken into consideration. Many studies forget to observe all these things. Very few well done studies shows significant increase in the POEM procedure after the POEM procedure, the presence of reflex as high as 48%. So reflex are also guarded in many different ways. Very few studies have addressed to all these different issues following a POEM and following a laparoscopic Heller's myotomy, of which all the 5 components, the total reflex time, upright reflex and supine reflex, postprandial reflex, and a worst demissed scores are not in favor of POEM. Then be aware in POEM, or for the matter in any achalasia, the first thing can be dysphagia or first thing can be recurrent reflex or aspiration. So if somebody is going to talk about post-POEM reflex, they should also take into consideration of respiratory inflammatory aspirate, salivary and food reflex, and duodenogastric reflex. These 3 components are very safely forgotten when POEMs are critically analyzed. At this point of time, the full large publication came out of Professor Ino's group 10 years before, but later subsequent outcome studies are an year to 5 years, whereas we have 10-year outcomes and 20-year outcomes in laparoscopic Heller's myotomy. We have to wait and watch at this point a similarly pitched outcome versus lap versus Heller's myotomy. Again, type-based outcome, laparoscopic Heller's is equal to POEM in type 1, equal to POEM in type 2, whereas type 3, POEM scores over the laparoscopic Heller's myotomy. Then as you move towards a mucosal breach, in laparoscopic Heller's myotomy, mucosal breach was considered as a complication, but in POEM, emphysema and perforation is not considered as a complication. Whereas now a caveat is added to both the procedures. Late identification or complication of perforation, which warrant a corrective procedure, is called as a complication. So unfortunately, this works, or all the studies have pointed out mucosal breach as a complication following a laparoscopic Heller's myotomy. So this is unfavorably pitched. I'm sure my colleague is going to pull out this issue. So at this point of time, it is very clear, no more a breach is considered a complication unless these 3 things are taken into consideration. So head on, it is one of the very major consensus on esophageal achalasia as recent as 2019. Operation time, length of hospital, reflex symptoms, erosive esophagitis, pathological acid reflux, there is no important difference. Of course, the quality of evidence and the heterogeneity is comparable. Whereas the post-operative ECAT score and length of myotomy favors the POEM, everything else favors similarly to both the procedures. Coming to the outcome, there are pros and cons which are being taken into consideration. There are other considerations apart from the indication per se. Whereas in laparoscopy, you have associated problem of hiatal hernia, problem of associated epiphrenic diverticula, and tight angulation of distal esophagus or severe esophageal tortuosity. Laparoscopic Heller's adds to the advantage. This is one study. Please follow it very carefully. POEM after POEM. This is one of the adverse event study followed by the large Chinese as well as the Korean group. One could see when there are not much of complication, what is the reason for one more POEM? If they can recruit 100+ patients for a repeat POEM, that obviously means there is something missing on the primary reporting of POEM information. This has to be taken into consideration, Chairman, when we are talking about repeat procedures after POEM. But of course, laparoscopic Heller's myotomy, there is a definite indication for repeat procedure, which we will talk about. So let us talk about laparoscopic Heller's myotomy after laparoscopic Heller's myotomy. Let us talk about primary POEM, which we have spoken, and repeat POEM after POEM we have spoken. where repeat poem after poem definitely is unfavorable to an extent. That obviously means they are done with expertise. Whereas poem after laparoscopic Hellas poem also, if you see, primary poem gives good results. If there is a previous Hellas myotomy, repeat Hellas myotomy gives 80% of the results. But let me say, a repeat laparoscopic Hellas myotomy gives as good as results as the primary procedure. Then we move on to something more important. In difficult achalasias, mucosally difficult achalasias, the submucosal fibrosis class 2 and 3, very huge sigmoid esophagus, associated diverticula. If you can see, this is a very typical thing, half crescent feel along the sides, and then you have a large diverticula. These things are technically impossible for a poem to complete a proper myotomy. And then you can see major adverse events of as high as 13.5%, which predominantly mucosal injury and gas-related adverse events which can ensue. So this laparoscopic Hellas myotomy is the only way out. Then submucosal fibrosis, if you can see these type of fibers, you can proceed with. If you see crossing fibers, then you have a high chance of multiple perforations. The more the number of perforations, you have more challenges in poem. This is very clearly a plus for the laparoscopic Hellas myotomy. Then this is the endoscopic mucosal inflammatory index or EMIA score. One could see there are various types of scores, type A, type B, and type C. Here, the more the mucosal changes, the more the presence of ulceration, the more the mucosal rugosity, and more the scarring, laparoscopic Hellas myotomy is clearly the choice. This is a large algorithm, but let me make it clear. This is for the revision procedure following laparoscopic Hellas and poem. Please understand, in PPA refractory GRD or anatomic failure of previous fundoplication, surgical revision or a partial fundoplication is the only considered option. Whereas in failed poem or failed laparoscopic Hellas myotomy, surgical esophagectomy is the appropriate choice for surgically fit patients who fail multimodal therapy. So failures of laparoscopic Hellas myotomy, failures of poem, surgery is the only solace at the end of the day. Symptom persistence, there are many publications on personalized approach which has been published in the medical journal, American Gastroenterology Group, where they have understood failures of poem are now slowly cropping up. They have understood failures, the mucosal popping out, the failure of myotomy, refusion of the muscular fibers, and then continuous and persistence of spasm, which obviously Amol sir can challenge me, no, it is an inappropriate diagnosis, but it's much more than that. To close down, laparoscopic Hellas myotomy versus poem, dysphagia relief is same. Post-procedural reflex, obviously poem is more than laparoscopic Hellas myotomy. Surgical myotomy definitely takes little longer time, but considering only the myotomy time, they are head-to-head. Length of hospital, considering the myotomy, poem or laparoscopic Hellas, the fundo adds to the little longer hospital stay, but head-to-head, statistically not significant. In conclusion, ladies and gentlemen, laparoscopic Hellas myotomy is for surgeons. Poem is for endotherapists. So the choice is very clear. Laparoscopic Hellas myotomy is for the surgical fraternity. Poem is for endotherapists. Thank you for the opportunity given.
Thank you, Dr. Kanagvel. Very well put. Let me stress the points you have mentioned. You said Hellas cardiomyotomy is an easy procedure, easy to train surgeons. There is significant reflex problem with, then you attacked the poem and said significant reflex with the poem, which is there in literature. You've also stressed the role of surgery in revision surgery, as well as in advanced cases like megaesophagus. You also encroached onto the poem contraindications such as esophageal significant changes in vascularity can limit the procedure. So with this, we'll go on to Dr. Amal, who will speak for the next 10 minutes on endotherapic treatment, which is basically poem here in this debate.
Thank you, Dr. Ishwar, and all the members of the IAGES for this wonderful opportunity to defend poem in front of a surgical audience. So achalasia versus poem, and with the permission of my honorable, opponent over here, Dr. Kanagvel, let me start by saying that we know that achalasia is a benign progressive disorder characterized by esophageal dysmotility and non-relaxation of the LES, And several therapeutic options are available, out of which we're going to debate on these two. But let us first understand that achalasia is a motility disorder of the esophagus with aperistalsis, defective LES relaxation, and impaired bolus transport and stasis of food. And there is actually no cure for achalasia, and whatever treatment that we are offering to these patients is basically palliative, because there is no way we can improve on the muscular contractility. So for those who may not be familiar with the POEM procedure, I just added this short video. What we do is we start in the mid-esophagus, approximately 10 centimeters proximal to the gastroesophageal junction. We create a submucosal tunnel by creating a 1.5 centimeters incision in the mucosa. We elevate the submucosa by injecting saline, and then we create a submucosal tunnel across the gastroesophageal junction. Following that, we confirm that on retroflexion in the stomach. Following that, we perform partial thickness, a selective circular or a full thickness myotomy, again extending beyond the gastroesophageal junction. We can see the circular muscle fibers and the longitudinal muscle fibers very clearly down here. And then further down, we create a full thickness myotomy. And once that has been completed, we confirm hemostasis, and then we come out and we close the mucosal incision using clips. This is the pre-POEM barium swallow, followed by the post-POEM barium swallow. And let me put forth a few questions. Is POEM safe and effective? So let us understand that POEM has been here for more than a decade now. POEM celebrates its 10th anniversary this year. And this is one of the review articles that we published just late last year, which shows that most of the studies so far, and studies having more than 1,000 patients, have shown that POEM efficacy is around 90% on an average when we look at all these studies. Not only that, but my honorable opponent mentioned that POEM results are still to be debated over long term, but this is a study that shows that the efficacy of POEM is maintained at 2 years follow-up without any problems. Now the second question is, how is POEM different from laparoscopic Heller's? So the first thing is that POEM can be performed in an endoscopy room using all these equipments. Of course, we need a standard gastroscope with a carbon dioxide insufflator and the knives and the generator, all these things. And this is very similar to what a laparoscopic surgeon would require. Of course, the scope would be replaced by a laparoscope instead of a gastroscope, but majority of the things, other things would be required. What is important is that in POEM, we have a full control in the extent of the myotomy. We can either perform a full thickness or a selective circular myotomy. Also, the length of the myotomy can be tailored as per the indication, which is very important in spastic esophageal disorders like type 3 achalasia, distal esophageal spasm, or Jackhammer esophagus, where one needs a much longer myotomy than a traditional myotomy that a laparoscopic Heller can ever provide. The other important aspect is that the phreноesophageal membrane, which my laparoscopic friends always comment about, is preserved. The hiatus is not mobilized, the vagus is not mobilized in these patients, and because of that, the GERD symptoms are, around 70% of these patients don't have any GERD symptoms, and mild to moderate symptoms may be present in about 13 to 16%, and severe in about 3%. We will address this in subsequently in further slides as well. Now let us look at comparative data comparing POEM versus laparoscopic Heller's. So there were initially 7 studies which have actually compared POEM head-to-head POEM versus laparoscopic Heller, and as Dr. Kanagwal mentioned, the efficacy and the adverse events are equal, and the operative stay time and the hospital stay is superior for POEM. POEM also reported lower ECART scores at 3 months and lower post-op lower esophageal sphincter pressure. However, those were not significant, and these were the differences. These differences have also been projected and been confirmed in meta-analysis, wherein the only differences were shown to be that of operative time, and equally efficacy and similar adverse events have been shown. Particularly for type 2 and type 1 achalasia, POEM has equally efficacy and safety as laparoscopic hilar myotomy, as Dr. Kanagwal mentioned. And this is based on these studies, and the level of evidence is 1 with the grade of recommendation of B, which is very strong evidence, which we published 2 years ago in these expert consensus statements. Particularly for type 3 achalasia, and let me bring it to your notice this point. This was a comparative study comparing POEM versus laparoscopic hilar, and the clinical response, we can say, was significantly superior for the POEM group, as well as for the adverse events, it was significantly superior for the POEM group as compared to the laparoscopic hilar group. So here, POEM is a clear winner for type 3 achalasia and spastic esophageal disorders. POEM is the way to go. Now coming to this next question about what about patients with failed laparoscopic hilar. So Professor Kanagwal mentioned that these patients actually are difficult to perform by POEM, but let me tell you, this is actually entirely the other way around. Because what is the advantage of POEM over laparoscopic hilar? The previous surgical myotomy is usually anterior, almost invariably, because as surgeons one cannot access the posterior aspect, and we can perform a POEM posteriorly. So we can go into a completely virgin area where the planes are very clear, and that can give us a very clear view of the planes, and we can perform a very clear-cut myotomy. Even if this is difficult, we can even go laterally if required. In addition to that, we have direct visual recognition of the submucosal layer, and mind you, this is magnified vision at 40x minimum. And the entire procedure of POEM is submucosal, because of which it does not alter the surrounding anatomy, because of which possibly reflux is less, but we will address that later. And there are less chances of fusion of the myotomy line because of the lateral dissection we perform in the POEM. So the tunnel is created much laterally, so that the muscle retracts much more laterally. Now, this is actually a study which compares POEM in nave achalasia as compared to POEM after failed Heller's myotomy. And this was a study in 181 patients over 11 centers, and which showed that the safety profile and the rate of clinical success is comparable in both groups. And let me mention very clearly that the technical success were comparable, and the results which Professor Kanagwal mentioned in this study as those patients who had lower results, slightly lower results in the post-Heller group is because of the duration of the achalasia and because of the sigmoidization of the esophagus. It has nothing to do with the myotomy per se. So that is very important to understand. Now coming to the last question, which is of most importance, as Dr. Kanagwal has pointed out, about post-POEM reflux. So I do understand, and I will accept this fact that there was an alarm about 3 years ago that post-POEM reflux was reported on up to almost 58% patients, to the extent that there was an editorial in one of the endoscopy journals, "Will reflux kill POEM?" But now let us look at these points in perspective. This is, again, before that, we need to discuss that this was another randomized study. This is the first randomized study comparing POEM with laparoscopic Heller, and which shows that reflux is definitely higher in POEM as compared to laparoscopic Heller myotomy. However, the results of POEM as far as dysphagia is concerned is non-inferior. This was a non-inferiority study, but here you can see that the percentage of clinical success was in favor of POEM 1.4%, but that was not significant to justify POEM over lap Hellers. But if we look at the study in more detail, we need to see that at 3 months, the incidence of reflux after POEM was much higher, but at 2 years, laparoscopic Heller and POEM had similar reflux rates, which were comparable. P-value was less than, higher. So it was not significant. And symptomatic reflux was much more comparable even as compared to these values. So what is important to understand is most of the POEM patients in the studies, they have evaluated reflux by PS studies, whereas most of the laparoscopic Heller myotomy studies have evaluated reflux in terms of symptoms. So we do have now methods to prevent or minimize post-POEM reflux. we need to understand that POEM is a procedure in evolution. It's only 10 years. Heller myotomy, described in 1913, as Dr. John pointed out, and the fundoplication was added only about 30 years later. Dysphagia was much common after the 360 full wrap, and therefore the partial wrap evolved. Most laparoscopic Heller studies don't report pH, and even today there is contention regarding efficacy of adding fundoplication to the lap Heller. In comparison, POEM is a 10-year-old procedure with an evolving technique which has been standardized only in the last 2 or 3 years. Anterior versus posterior, selective circular or full thickness, and especially length of myotomy, importance to the sling fibers, and most of the studies on POEM currently are reporting studies more than 5 years ago. And all these studies are based on PS studies. So as I mentioned, gastric myotomy is an important marker and important factor in predicting post-POEM reflux, as it is truly for laparoscopic Heller as well. And we know that more than 2 centimeter myotomy on the gastric side is associated with longer, higher reflux. The second important point is when we are performing POEM, and particularly posterior POEM, we encounter the perforating vessels at the gastroesophageal junction. And on the left side of this junction, this perforating vessels are the sling fibers of the G junction. Now we know that our myotomy has to extend only on the right side of these perforating vessels, not onto the left side, and which Tanaka et al. Reported in 2 years ago that this has shown significant improvement in the post-POEM reflux results. Further to that, we can now add a fundoplication endoscopically to the POEM procedure very easily. We do agree that POEM and laparoscopic Heller have very equal results when we are talking about type 1 and type 2 achalasia. For type 3, POEM scores over laparoscopic Heller. And what is very important to understand is that POEM is no longer a new procedure. It is probably the fastest acceptance to any new procedure in the history of medicine, and it has an excellent patient acceptance with a high popularity. And the reason being that POEM is less invasive, results are comparable to laparoscopy with low hospital stay and very minimal adverse events. Conversion to laparoscopy or open is practically unheard of. There is no scar, and symptomatic reflux is in the tune of 10 to 16%. So friends, it is time for surgeons to accept that POEM is here to stay. And as Dr. Kanakwal mentioned, I would just like to rephrase that statement. Who should be doing POEM? Whether surgeon endoscopists or endoscopists with a surgical know-how. I think it is for us IAGES to decide. Thank you so much.
Thank you, Dr. Amal. To just summarize what you have been saying, you have proved that POEM has got better myotomies. You also mentioned the importance of intact hiatus, the hiatus being left alone so that the reflux is less. In fact, you went to the point of almost initially downplaying the reflux after the POEM, but subsequently you did very sheepishly brought on transoral incisional fundoplications as an endoscopic procedure, which I grant that given time will play a major role. It is, we also know from your talk that you have been doing posterior redo cases, and they are possible not only in failed Hellers, but also in failed POEM procedures. But I thought you downplayed the myotomy, because surgically, the myotomy has to be at least 180 degrees. For any procedure to be accepted, it's got to be locally available. Just 1 or 2 people doing it, just a handful of people doing the procedure is not good enough. So you need to train more people as well. So I'll give you 2 minutes to each of you. First to Dr. Kanagawal for rebuttal and also defending his talk.
I'm happy at least 50% or 70% of what I told is already concurred by Dr. Amal. That means my job is already done. Number 2, he talked about the complications of laparoscopic hairless myotomy. Moderator, if you can pick up all the complication papers were at least 2012 and proximal to that years. As the science of POEM evolved, the capability of the laparoscopic surgeons also evolved. So the last 10 years of laparoscopic hairless myotomy is almost perfected. The conversion rate in the last 10 years is 0.4%, not as high as what Sir told. As the longevity of the laparoscopic hairless myotomy exceeded 10 years, I do agree with him. The chance of dysphagia, worsening ECAT score goes above 10%. The same thing as will go when the poem also is studied more than 10 years now. Number 2, hiatal dissection is the word which he was trying to floor me. Please be aware, Chairman, hiatal dissection, once the poem fundoplication come, it holds the same and good. So we have to wait for the amount of reflex which is going to come after hiatal dissection for the poem fundoplication. And then at this point of time, type 1 and type 2 of the achalasia forms at least 80 to 90% of the achalasia. Type 3 is less than 10%. I agree with my colleague that type 3 poem scores much better than the laparoscopic hairless myotomy because the extended myotomy is possible with that. Revision myotomies, which my colleague was talking about, it is not that one area which is virgin and the other area is not virgin area. After a myotomy to do a revision, you do a lateral myotomy, the fibrosis is extending beyond that. That's why they go dimensionally across or at least 60 degrees across than the earlier myotomy. Unfortunately, the poem myotomies are never linear. It has an oblique or they go from anterior to medial or anterior to lateral. They are comparable procedures. Myotomy is the same principle. The only axis is peroral and only axis is per-abdominal. Apart from that, at this point of time, I'd like to reiterate availability of expertise should guide the patient to the type of procedure. Thank you.
Thank you, Dr. Kanagavel. You're almost up to time. Dr. Amol, for your 2 minutes now.
Right. So, Dr. Kanagavel, I fully agree with you that I did concur with you on several points. One being that poem and laparoscopic hellers, the results are the efficacy is the same. However, mind you, you can go back to my slides and see that the reflux, what has been reported post-poem is after PH studies, whereas most laparoscopic heller myotomy results are without PH studies, and they are based on symptomatic reflux. And if you notice, even after poem, symptomatic reflux is to the tune of 10 to 16%, which is very similar to laparoscopic heller myotomy. So most of the studies were done earlier when PH was not so easily available. The second point being that availability. Now, who decides availability? And not everybody is fortunate enough to have expert laparoscopic surgeons as yourself, Dr. John, or Dr. Ishwar. Now, it always depends, and when we come across these debates, it's probably the best of the centers who are doing both that we are comparing. So let us leave that to the community because there obviously the patients make the choice. But mind you, in the last 10 years, that poem has become popular and it has become visible. You can tell me honestly how many laparoscopic Heller's patients are coming to surgeons and how many poems are being performed by endoscopists. I'm talking even about surgical endoscopists like me. So that is based on the patient perception, and that is how the open to laparoscopy switch also happened about 30 years ago. Remember that. And the third point is, I would very clearly like to disagree with you on one point that the poem myotomy is not vertical. It is very much vertical, sir. It is vertical to the extent that in a sigmoid esophagus also we follow the direction perpendicular to the circular muscle fibers. So it is never oblique. In fact, in laparoscopy it could go oblique, but in poem it is never oblique. With that, I would still say that poem is the way to go wherever it is possible. I agree today availability is limited, but it will only grow if more and more surgeons take it up. Thank you.
Thank you very much, sir. Well, just to sum up everything, as you rightly said, Dr. Amol very rightly said, laparoscopy became popular because of patients more than I think by surgeons, because they preferred something that not really surgical, though we know it's surgical. Same way, I think if I were to offer an endoscopic procedure to a patient or a laparoscopic procedure, they would definitely prefer an endoscopic view, though I would hate to say it because I don't do the poem. This brings us to the problem of whether it should be done by the surgeons or by the physicians. I think anything that's done by the surgeon is taken over by the physician because they have the endoscopy along with them. But it's good for surgeons to train in both and probably initially, as you're saying, for training, maybe have a combined team, and later on, you know, the interventional radiologist will watch it and probably take it over from both of us, as they've been doing in other areas. I must confess that though Hellas has got very established record surgically speaking, POEM is the new kid on the block. We should give it time. We had a rough time with Hellas. Initially, we were doing a myotomy. Then should we be testing it? It was on the tip of my tongue. Should we be testing to see whether we perforated the esophagus? No, we wait for the post-op thing. But I'm sure new things are coming up, new dyes, new ways are coming up. So we should give it time. After all, this kid has been around for 10 years, whereas the other man is an old man. He's about 90 years old. So we should give it a bit of time for it to grow. So I would tend to lean, though I don't do, I would tend to lean more towards POEM as a future. But we need to train in both. And we cannot close our eyes to laparoscopy, because one day, if somebody walks through the entire esophagus, which I expect somebody to do it somewhere along the line, it will be the surgeon that's closing it through the laparoscope. So with that, I'll wind up. I thank both the debaters for sticking to the time, and also to the IAGES membership.
Thank you, John, Amol, and Kanakavel for this evidence-based, very entertaining debate. I'm sure all our delegates also have thoroughly enjoyed this friendly, fact-filled debate. And thank you all. Now let us all move on to watch the virtual plenary session happening, starting with the presidential oration. Thank you all.